Good afternoon. I am Dr. Angela Hoyos. I am a neonatologist, and I am head of neonatal intensive care unit in Bogota, Colombia. It's a pleasure and it's an honor to introduce you Dr. Khurshid Mohammed. He is a friend of ours for many years, and we are very happy to have him with us. He is a neonatologist who lives in Calgary, Canada. He's associated clinical professor in the University of Calgary, and he is the head of a neonatal intensive care unit caring for neurological patients. This is a very interesting way. We would have loved to have those sort of units in our countries. He shared with us this protocol called Drive to Zero intraventricular hemorrhage, which we have used, and we thank him very much for having shared it with us because he has been very helpful. He also has taught us echo, especially the one from the head. He has been in Latin America several times, and he has developed a maniquí so he can teach, and he has done some studies about how to teach this echo for neonatologists. He also is an expert in hypoxic ischemic encephalopathy and how to care for these patients. And he shared with us this app that will let us in the phone choose which patient would benefit from hypothermia. He has published a lot of work in these three areas, and he has done a lot of talks around the world. So we are very happy to have him with us. Thank you very much for coming or being here. And so go ahead, Dr. Khurshid.
Hello, everybody. Thank you very much for the kind introduction, Dr. Hoyos, and for giving me the opportunity to present today. It's such an honor. And in fact, the study that we have published on the efficacy of teaching head ultrasound using the simulation was with the team in Quito and with participants from all over South America. By choosing this title, Dancing with the Brain, I wanted to drive the main point of the talk home. That is, thinking of the brain as a member of the human body family, not a separated organ in an isolated bubble. The more specialized we become, the higher risk of developing a tunneled vision, where we lose prospect of the big picture, especially with a devastating problem such as HIE. Today, I will propose to you a systematic approach to the problem and hopefully bringing back the big picture approach. I have nothing to disclose. The objectives of my talk are to touch base on how we can improve HIE prevention, identification, outcome measures, prediction, and finally, neuroprotection. Before doing that, we need to understand the physiology and pathophysiology of the problem. I highly recommend spending enough time upfront doing that, as it will pay off later. Let's start with brain autoregulation. The definition of autoregulation is the process by which organs and tissues self-regulate blood delivery. A good analogy for brain or cerebral autoregulation is water flow to several houses, in our case organs, and different rooms, in our case tissues. Within a house or houses, the ones with higher demands will receive more water flow. Same goes for rooms and places with higher consumption, such as the shower room and backyard on a hot day. Along the same line, more important and vital houses will take priority in receiving water flow in case of reduced in the supply. In our case, in case of ischemia or cord prolapse, for example, if there is enough time for the brain to divert the blood flow, it will preserve the vital organ, which are the deep gray matter, on the expense of white matter. If there is no, then the area that will get hit harder are those of high metabolism, like the deep gray matter. At capillary level, on the left, you can see what normally happens if there is too much flow to the brain. The capillary sphincters constrict to decrease the amount of blood flowing to the tissue. The opposite happens on the right, where the sphincters relax, allowing more flow going to the tissue. Now, if we compare the adult autoregulation curve here to children and neonates, you will notice that the curve is steeper, narrower, and shifted to the left, meaning there is narrower safe margin for blood pressure to fluctuate without causing trouble in the brain. These curves are in healthy subjects. Neonate is a completely different story, and the curve is almost flat or pressure passive, meaning the higher the blood pressure, the higher the blood flow to the brain, and vice versa. The second physiologic concept is ischemia versus hypoxia. We all use hypoxic ischemic encephalopathy, which can be sometimes misleading, as the fetus is used and adapted to hypoxic environment, but is very sensitive to ischemic incidents. All animal studies were designed using pure ischemic model, not only hypoxia. Hypoxia is just one element in the ischemic process. One of the coping mechanisms for a fetus is having fetal hemoglobin, which has very high affinity to oxygen and releases it only in a hypoxic environment, which in a way breaks the cycle of hypoxia. There are some studies now showing that resuscitating hypoxic ischemic encephalopathy infant with 100% oxygen might be harmful, which makes physiologic sense. This graph is showing nicely the two phases: ischemic, the blue brain on the left, and reperfusion, the red brain in the middle. Somewhere between the ischemic and the starting of the reperfusion phase is our therapeutic window for cooling. The duration this window has been reported differently. Some, such as the previous study or paper, stated that the reperfusion phase starts in about 30 minutes, as compared to this one, which reports up to 6 hours window. It's classical for our window per therapeutic hypothermia. The reality is it varies depending on the time, frequency, and severity of the sentinel event, and also on the newborn itself and the efficiency of the resuscitation effort that we are doing. Think about it like a natural disaster, like earthquake or flood. The initial distraction cannot be avoided, in our case, cell necrosis. We cannot do anything about it. But the aftermath, which is in our case reperfusion, and what brings with it of pandemics, epidemic, and poverty, can be mitigated by mobilizing resources and support, and in our case, neuroprotection strategies. What happens at the cellular level in general and in a very simplified way is the influx of calcium, which triggers the free radical storm that eventually destroy the cell immediately or by triggering apoptosis. Now moving to our objectives, and the first we will start with prevention. The incidence of significant HIE per 1,000 live births is shown in this graph. You can appreciate a big gap between developed and developing or resource-limited countries. This reduction in the developed countries is not due to therapeutic hypothermia only. It cannot be explained by therapeutic hypothermia only. In a way, this is a good news because there is an opportunity here we can take to decrease the incidence of hypoxic ischemic encephalopathy globally. Furthermore, after the therapeutic hypothermia era, the reduction in mortality and morbidities continues to improve over time, even in developed countries. This is mainly due to the improvement in the overall patient care and resuscitation. In terms of risk factors, I am afraid I don't have any good news for you. We have looked at this in the span of 15 years in Alberta, linking the obstetric and neonatology databases. We looked at 1,588 infants with asphyxia admitted to NICUs between 2002 and 2016. The overall incidence in Alberta was between 1.5 and 2.5 per 1,000 live births. And in terms of risk factors, we identified that all the risk factors were not actually preventable. There were more lifestyle factors such as hypertension, obesity, diabetes, and complications related to these problems, such as placenta abruption, large for gestational age, small for gestational age, etc. Now, fetal heart rate monitoring is a promising tool if we know how to interpret it and act on it promptly. If you haven't read Dr. Berry's Schifrin's work or attended his talks related to fetal heart rate monitoring, I highly recommend you to do so, as it seems an artistic science if the term is allowed. The second objective of the talk is improving identification of hypoxic ischemic encephalopathic infants. As we all know, we have three sets of criteria when it comes to cooling. First is the screening criteria, that is gestational age and birth weight. Most centers use more or equal 35 weeks gestational age at birth. Some decrease the gestational age to 34 weeks, but I haven't heard of a center gone below the 34 weeks, probably due to the evidence of increased mortality with cooling in preterm infants with asphyxia. For birth weight, most centers consider birth weight above 1,800 grams as eligible for therapeutic hypothermia. The second set of criteria is criteria A. You would think it should be consistent and straightforward across the board and studies, but it's not. This table summarizes criteria A in major studies, and as you can appreciate, it is a little bit different from one study to another. The third set of criteria is criteria B, that is encephalopathy assessment, which was first described and invented by Dr. Sarnath and his wife in 1976. They studied 21 units born at or more than 30 gestational age suffered from acute, not chronic asphyxia. In another word, it wasn't meant for partial prolonged asphyxia pattern, which I will explain later. They carefully examined these infants frequently and performed and interpreted EEGs themselves. And then they came up with the famous 3 encephalopathic categories, which we all use since. All this is good, but applying criteria A and B is challenging in real life. We often left scratching our heads wondering what to do. To cool or not to cool is the question. This was a very nice study from Australia. They used their own criteria and looked retrospectively at their HIE cohort. They found close to 50% of diagnoses were inaccurate, which is scary. In the coming slide, I will present our to this, which is one way of looking at it, and certainly is not the only way. It is important, though, to highlight that whatever you decide to develop and try to do to approach this problem, it's important to be consistent to allow you to assess any intervention that you are doing. This part in quality improvement is called process measures. We initiated several interventions at the same time or soon after each other. The goal was to improve precision in the diagnosis, that is, getting the correct diagnosis each time we use the tool. First step was to develop a decision-making tree which walks the frontline providers step by step by asking and answering questions and help in making the decision level 3 transport team or not. And then the second step was to take our cooling criteria and put it into a smartphone application. We realized that under stress, when the clock is ticking and the window is becoming narrower and narrower, it is very challenging to access the many pages cooling protocol and decipher the cooling criteria. So we put it together in an app where you can answer yes and no, and the app application will tell you whether the baby is eligible for therapeutic hypothermia or not. This is how the application looks. Your criteria may look different from ours, which is fine. You can develop your own smartphone application. It is pretty simple and will increase the compliance of using your criteria significantly. The one message though, the simpler you make it, the more people will use it. The more complicated you make it, the lower the compliance will be. We also realized that the application is as good as the accuracy of the information fed into it. In other words, garbage in, garbage out. So we developed a targeted neurological examination teaching video specifically for cooling assessment and made it available. Again, this is based on our criteria, which can be modified and tailored to other centers. Two more issues where we haven't addressed. It is impossible to teach frontline providers and trainees abnormal neurological hands-on examination on a moderate to severe hypoxic ischemic encephalopathic infant for many reasons. We tried to be creative and took the recorded teaching videos for targeted neurological examination, then transformed them into virtual reality model. As you can see on the left here, the student is watching normal baby, then seizing one, then performing pupil reaction to light. You can also see myself performing a tone assessment. And in this video, I'm doing the ventral suspension. And the last piece was a feeling. Of the neurological examination, which we try to address by creating a doll with variable tone at joint level. And you can see now Norma, our lead nurse, is performing the tone assessment on the neurological examination tone. We are planning to test the efficacy and the efficiency of this method against the traditional teaching. And if it's proven efficient, that it can replace the traditional method of teaching neurological examination. The last piece was documentation. You can develop a very accurate and sophisticated document which is perfect for research purposes, but it becomes cumbersome and hard to implement. We elected to take the most important element and put it on a sticker. Physicians can peel and stick on the chart. One thing worth mentioning is we advise to perform the neurological examination for the purpose of making the decision to cool or not to cool after 1 hour from birth. And that's to allow enough time for stabilization and avoid shifting the focus from resuscitation, which is far more important than cooling. A good, efficient resuscitation is the best neuroprotection strategy you can do for a baby at risk of asphyxia. Now, thing is in place. It was time for us to spread the knowledge. All this work would have left little impact hadn't we decided to reach out in person and visit referring centers. This is an overview of the province of Alberta. We cover the southern part of the province with more than 27,000 births per year and more than 1,200 admissions to our level 3 NICU. In 2016, we decided to make the move. Under the leadership of Dr. Thomas and Renee Paul, we eventually visited every single referring center in southern Alberta for a day session, which included didactic lectures, hands-on simulation, case discussion, and small group meeting with stakeholders to put strategic planning. Then we took it one step further with another initiative which was completely new to us under the leadership of Dr. Ayman Abu Mahram, where he set up a telehealth infrastructure at these centers to follow up our inpatient in-person visits with virtual connections. He started with only one center with very low compliance initially. But then over time, with patient and persistent, he has all centers connected through a full network and a full program called Virtual NICU. We use this system, for example, to watch the physician performing targeted neurological examination. By using this tool, we cooled eligible infants who deemed initially not encephalopathic, and we avoided unnecessary cooling in some cases. All this also kept our moderate to severe HIE incidence stable over the years between 30 to 40 cases, unlike many centers where their incidence got inflated by including more mild HIE cases. At the same time, it decreased the percentage of missing eligible infants from 20%, which is close to our national average in Canada, as low as 4.5%. Now, moving to outcome measures, which is also a cornerstone in any quality improvement initiative. Whether you use cranial ultrasound or brain MRI, the important point is to have it done at the same time, as much as possible, using the same scoring system, which proven strong inter-observer reliability and reasonable positive and negative predictive value. Brain MRI is the gold standard for the diagnosis of brain injury in HIE, and there are 4 classic patterns in HIE. The first one is at the acute profound asphyxia, where the deep gray involved mainly the optic radiation, the splenium of the corpus callosum, hippocampi, and the bottom of the sulci and gyri, and the motor sensory stripe. And this, from the terminology, is acute and profound. Short time period, but it is very profound. There is no time to divert the blood, so the areas with high metabolism suffering the most. The second pattern is the partial prolonged asphyxia, where it's partial, but it's over long time. So there was enough time to divert the blood from the non-essential parts to the essential ones. So the area that gets suffered is the white matter watershed area, subcortical and deep. And then if you have both deep gray matter and white matter involved, then you get a total or global asphyxia, and that's the worst type of brain injury. And the last one is the multifocal, where you have scattered white matter injury here and there. This is how it looks in real life. These are the diffusion weighted image, and the areas which are bright are abnormal. So you can see here the basal ganglia is involved and the rest of the brain is fine. So this will be an example of acute profound asphyxia. And this is an area where the deep gray matter is intact, so you don't see any brightness here, but the subcortical watershed white matter is involved. So this will be an example of partial prolonged asphyxia. And where there is a deep gray matter and the subcortical white matter involved, it will be a global or total asphyxia. And the last one is a scattered bright spots of white matter injury here and there, and this will be the multifocal asphyxia. Now, the second question that comes with the MRI is when to perform the MRI. what is the optimum time to perform the MRI. Preferably, it should be between day 4 and 5 when the diffusion changes are maximum. Keeping the timing consistent will help you assessing your intervention and risk factors. But when it comes to counseling the family, it becomes less and less relevant as because of the hypothermia, the diffusion changes is prolonged. So you can do it day 6, day 5, day 7 sometimes, that's okay. But from the quality improvement and auditing perspective, it's better to keep it within a very narrow window to be able to assess your cohort consistently. MRI in predicting the long-term outcome. I can say it is pretty good, but at the end of the day, we all have seen it all. We have seen the full good MRIs with bad outcome and bad MRIs with very good outcome. I call this the tale of two brains, similar to the tail piece. So one brain in general, infants with pure acute profound asphyxia pattern, like this case. Infant born at home required extensive resuscitation, but turned around quickly without requiring much support and medications. When we did the MRI for this kid at day 4, it showed the isolated gray matter or basal ganglia injury. And this is where your cortical spinal tracts, they run through it. So if you have an injury in this area, it puts these babies at very high risk of motor problem because the rest of the brain is fine. This is the ADC map, and the same area that we have seen where bright on the diffusion weighted image, it will show as down the apparent diffusion coefficient or the ADC map. And the same baby, we repeated the MRI on day 10. This is the T1 weighted image, and it will show bright on it, and you can see the same, the corresponding area, now it's bright. And these are the areas of permanent injury. So this kid had severe cerebral palsy, but very reasonable cognitive outcome. And brain 2, on the other hand, is the case with similar presentation, but with a story of decreased fetal movement 24 hours before delivery, required extensive resuscitation, was ventilated, and required inotropic support, and with refractory seizure requiring multiple anti-seizure medication. The MRI day 4 showed the global asphyxia. You see the subcortical white matter watershed area, dark, the restricted diffusion, the splenium of the chromosome, the optic radiation, and the both thalami were involved. But I want to draw your attention to the symmetrical, homogeneous involvement of the thalami. Wherever you see this injury, think about diaschisis. And the diaschisis is a type of injury that can resolve over time. Nevertheless, because of the nature of the injury, of the global asphyxia, the bad EEG, the refractory seizure, the bad examination, we decide to withdraw care from this kid. But the kids start to breathe and start to bottle feed, so we didn't make much sense. So we repeated the MRI on day 14, and you can see the area of the deep gray matter in the thalami has completely resolved, because if this was a permanent injury, we should have seen bright areas on the T1 weighted image. And the coronal, you can see the cortical spinal tract myelination is intact on both sides. So at 18 months, you can see that the white matter loss and the brain atrophy as compared to relatively preserved deep gray matter. So in hindsight, this was bad partial prolonged asphyxia, and it wasn't total asphyxia. So this kid now has severe language and speech delay, but has no motor delay whatsoever. So if you want to remember a rule of thumb, that if you have a pure acute profound asphyxia with deep gray matter involvement, then the risk of motor disability is much higher as compared to cognitive disability. On the other hand, if you have a white matter injury, not deep gray matter injury, then the risk of cognitive problem is much higher as compared to motor problems. I haven't addressed brain monitoring and EEG as it deserved a separate talk, But in general, the background recovery is more important, and the EEG is better in predicting seizure at 1 year and beyond as compared to MRI. These are the usual classic 4 patterns. A is isoelectric, where you have very minimum activity. This is the burst suppression. We see the bursts are here, and in between there is quite suppression, and then you get discontinuous with the 2 distinct patterns. One pattern is here, and then other pattern, and then you get the seizure when the EEG become more like ECG. Now, I spent the largest part of my presentation talking about building the ground rules and foundation, as I believe by going through this exercise and spending enough time to establish the infrastructure, this will make everything easy and almost on autopilot. On the other hand, if we attempted to get some easy wins, we will face lots of frustration and create an environment of pessimism. So let's talk about neuroprotection. The first step in a neuroprotection package or intervention is building your audit tool and start auditing. And I can guarantee you by just doing that, you will improve the outcomes. How many of us slowed down when we saw a police car on the side of the road? Certainly do every single time. It is just the human nature. And then the other thing is like putting it under the nice analogy, an umbrella that makes sense when you talk about your intervention. And we decided to put it under the umbrella of hibernation. It's what we are really trying to do when we cool this infant is to hibernate the brain until the storm passes along. So we have our statement saying, "Don't poke me, I am hibernating." Jan Lind is our co-nursing lead of the neurocritical care program. She developed a mnemonic to help identifying the priorities of neuroprotection care called Hibernate. She gave a brilliant talk about this, which I highly recommend to watch. So Hibernate stands for hypothermia, integrating family involvement, boundaries, environment, recognition of rest and recovery, nutrition, assessment tools, and EEG. There is a shift in our thinking from focusing on the brain as an isolated organ to think about it as a member of the human body family, working in synchrony and harmony and consistent communication with other organs, which is great. This is a very nice recent review article exploring the multi-organ nature involvement of hypoxic ischemic encephalopathy. If you haven't read it yet, I highly recommend it. What we have done, we developed a one-page to summarize the multi-system approach from diagnosis to treatment in HIE to make it easy for a physician and trainee to follow. So starting with respiratory management, we as other centers have moved away from keeping these kids ventilated till post-cooling and MRI. In fact, we just follow the clinical need and deal with them as any normal NICU admission. When we also try to keep their CO2 within the normal limit. However, when we first looked at the CO2 data, infants with at least one arterial CO2 above 60 in the first 72 hours had lower rate of brain injury, which didn't make a lot of sense given the nature of injury is a reperfusion one. As you know, CO2 is a potent cerebral vasodilator. If you have high CO2, you should exacerbate or make the reperfusion injury worse. But then we realized that the blood gas machine warms the blood gas sample to body temperature, which overestimates the CO2. What was hypercapnia in the blood gas machine was probably normocapnia in the cooled infant blood. We have shown that in this study, which is in preparation for submission. PPHN is another dilemma that we don't have clear answer for. What we found, though, is the severity of PPHN was not correlated with higher incidence of brain injury on MRI in HIE infant. However, if the PPHN was severe enough to the point that made the bedside physician to discontinue the cooling, then it was associated with much higher mortality rate. Whether to discontinue cooling or not, if the PPHN is not responding to usual treatment, is not clear yet and up for debate. Hemodynamic instability. For years, we defined hypotension as mean blood pressure below 40 in the term and near-term infants, which caused lots of iatrogenic treatment with inotropes. This can be potentially harmful during the reperfusion phase with pressure-passive brain perfusion curve. What happens usually if we follow the mean arterial pressure below 40, we start dopamine or dobutamine. And if the brain is pressure passive, then suddenly your blood pressure shoots up and more blood goes to the brain and exacerbate the reperfusion injury. We did show that in a study that we performed, we showed that the use of inotropes was associated with higher incidence of brain injury or death, or a composite of death and or brain injury on MRI after all kind of confounding factors. This prompted us to protocolize our hemodynamic management, combining clinical, laboratory, and blood pressure measurement factors. And just by doing that, we were able to significantly reduce our use of inotropes over time, as shown in this graph. And that was true for all kinds of inotropes, whether you look at overall inotropes, dopamine, and normal saline boluses. Nutrition, fluids, and electrolytes. We now allow our parents to actually hold their infants during cooling if possible, if the baby is stable enough. And I can tell you this has been the most rewarding intervention among all. The first mom we allowed to hold her baby was this one in the picture. And as you can see, there was no barrier. We didn't put any pillow to protect the mom. And she almost burned her hand because it was so compelling for her, and her eye just burst in tears when she found that. Since then, we are, of course, like putting a barrier and pillow under so we can protect the parents. But it's remarkable how much they appreciate that. We also start trophic feed now. We don't keep this baby's MPO for the first 72 hours. We used to do that forever, but there has been some studies coming, one of them comparing a cohort in the UK to a cohort in Sweden, and they showed that there was no difference and there wasn't any higher risk of NIC if you started trophic feed earlier. We usually start the trophic feed once the lactate normalizes, usually within the first 4 hours. We give them either frozen expressed breast milk or donor human milk. If the fresh expressed breast milk is not available, we prefer the fresh colostrum or expressed breast milk because it contains stem cells. And as you know, stem cells can travel and get converted to the organ cells and repair potential injuries. Regarding the skin care, our rate of subcutaneous fat necrosis has decreased as well, although it's hard to quantify due to the underreporting. The intervention beside the skin care protocol that we have, they were the reduction of inotropes use. As you know, inotropes can cause peripheral vasoconstriction, allowing kangaroo care during cooling, and the use of blanket that can be wrapped around the baby so we can move the baby around and don't keep them in a still position. Early nutrition and the introduction of phosphate in the TPN. And what we found that babies who went cooling, they had significantly higher the calcium level compared to babies that weren't cool when we adjusted for severity of the HIE staging. And that was probably because of the HIE is as a neuroprotective, it prevents the influx of calcium into the cell. Regarding infection, we use cefotaxime instead of gentamicin to avoid nephrotoxicity and ototoxicity. Also, there are animal studies showing that third-generation cephalosporin can prevent epileptogenesis, and we know that if there is cortical injury, these babies are at risk of having later on epilepsy due to epileptogenesis. So there is a potential chance that it can be neuroprotective. Follow-up, we need to follow these infants up for two reasons. One, to assess our acute and early intervention, whether they work or they are harmful, and also for early identification of outcomes and early intervention to improve those outcomes. And this is just an example of how we follow them up in our neonatal follow-up clinic with parallel service by the neonatal neurocritical care team, which takes over after around 5 years of age until almost teenage age. Finally, is it worth it? All this effort, all this time that we have been doing for more than 6 years, planning and implementing, when there was not much evidence and we were just relying on our belief and enthusiasm and common sense. Does it work? And as they said, the proof is in the pudding. So we showed that with the early implementation of the program, especially the brain monitoring component of it, we were able to improve the accuracy of seizure diagnosis. Before the implementation of brain monitoring, we as a team were afraid that we are missing seizures, so we tend to over-treat the seizures. And as we know from the literature that our ability to diagnose clinically is very poor, even with the best eye. So by introducing the monitoring service, we were able to improve our accuracy, and also we were able to decrease the anti-seizure medication burden significantly, and there were much fewer kids got discharged home on anti-seizure medication. And second, by teaching our nurses to set up a full EEG in the unit, we moved from having no form of brain monitoring, even amplitude integrated EEG, to having a full EEG service, because the nurses stepped up and they were willing to learn how to set up this full EEG. We were able to show that we decreased the time to initiation of EEG study from a median of 39 hours to 7.5 hours. And we decreased the hospital stay significantly. And by implementing the full program and the full neuroprotection package and drawing the map of brain injury in HIE and having an action plan for each items of the map, where we were able to show a reduction in mortality and brain injury by MRI and mortality and or brain injury on MRI. And we were shown that this was indeed due to the intervention, not due to the change in practice over time. And we did that interrupted time series analysis, and we corrected for all kinds of confounding factors. And finally, by implementing the outreach program, we improved the care at many levels. The use of inotropes, the use of anti-seizure medication, the use of normal saline boluses, and we reduced the rate of mortality and brain injury and the composite of mortality and or brain injury. We also improved the time to referral, so the referring centers were referring the cases for us sooner. And we also, as I said, we avoided some unnecessary cooling by using telehealth or virtual in ICU. And also we cooled some cases were deemed not eligible initially. Now, one word on neuroplasticity. Brain injury is not a death sentence. Babies can recover from devastating injury when we put them in the right, positive, interactive, loving environment. And this is a huge window for hope. And hope is one thing you don't want to take away from parents, as hope and involved parents are the strongest factors in improving outcomes, almost regardless of the severity of the injury. It can make up for any type of injury if you have the right environment and the right parents. And it is all beautifully captured and in a way carved in stones in this piece of art made by our NICU nurses. from classic reading, breastfeeding, music, physical exercise, skin to skin, holding, having extended family, etc. Those are the bread and butter of brain plasticity. So one of the examples I wanted to mention about the neuroplasticity intervention is the reading. So this was an elegant study. They call it the Goldilocks effect. If you know the Goldilocks story, it's a blonde girl coming to visit 3 bears, and they weren't there. There were 3. They left their food behind, and she was trying them one by one. She couldn't eat the father's porridge because it was too hot, and she couldn't eat the mother's porridge because it was too cold. But she could eat the cub's porridge because it was the right amount of temperature. So what they did here, they put kids at around 3 years of age into functional MRIs, and they read for them the same story in 3 methods. One was as an audiobook, and one they watched it as animation, and then the third one was classic, somebody sitting and reading the book for them. They found that the animation was too hot. It confused the brain, and it lit up many areas in the brain. And the audio was too cold. It was very few areas in the brain were stimulated. And the right amount was the classic reading, the classic old-fashioned reading. And there are many other interventions in terms of neuroplasticity. Now I will finish up with the brain number 3. So in brain number 3 was a term baby with all risk factors for brain injury, from inotropes use, hypo and hypercapnia, refractory seizure, and hypoglycemia. So this baby had an MRI, and hopefully it will work. Anyway, the MRI was reported as total asphyxia, and we gave the family a grim prognosis that there is no way that this baby won't be disabled. There's 100% chance of disability in this kid. And yet, she turned around beautifully. And in fact, we discharged her early from our follow-up clinic because she was ahead of her peers in all domains. This family was very involved, very positive. They put her in all kind of activities, music, physical, and reading programs, and she turned around from the brain injury she had. Couple of recommendations I leave you with. Our neonatal neurocritical care lecture series contains many useful lectures that you can access for free. Also, you can access the Newborn Brain Society webinars once you become a member through our portal. And with that, I am beyond thankful to our team and families. Without them, we wouldn't be able to achieve this. And we also have fun most of the time. Here are our fellows learning how to set up an EEG study and troubleshoot on my scalp. And below is a single channel EEG to test your ability to focus. We use that during our nursing retreat. Thank you very much. I'll be happy to take questions.
Good afternoon again. How are you? There are a few questions, and The first one is about the application to decide if to cool or not to cool. If you can explain how to get it. The iPhone used to have this application, and we no longer can download it. So could you please explain if it has changed?
Yeah, thank you very much for the question. I got this question a lot. Unfortunately, my app developer failed to renew his membership, so that's why it fall off the market. But there is a way of putting it in any smartphone application. I can share it with you. You can create a shortcut because it originally was a desktop application. So basically you go to the website and create a shortcut to your phone, and can be used in any smartphone, not only iPhone. So I will share that with you, and then you can share it with the group.
Okay, so we can put it in the web page, okay?
Yeah, perfect. Web page, any phone, any smartphone, you can put it. That's
Okay, a second question is about if you put your baby in cooling and you find out afterwards that the baby is not really doing so, the opposite, is doing very well, and you think that maybe it isn't good to keep it cooling, should you take him off, or should you continue to have it on hypothermia?
Yeah, so we initially thought like we were going with like terminating hypothermia if the baby's neuro examination was normal at the level 3 or the referral center, and we put the EEG on, and if the EEG was completely normal, then we stopped the cooling. However, few of those babies ceased afterward, and when we did the MRI, it showed there was some HIE changes. So right now, what we are doing, if you committed for cooling, we continue for 72 hours, especially with the more data coming from other centers and studies that actually recommend to cool even mild HIE. What we started to work on though is to improve our identification meanwhile. So the number of the time that will end up with such story has decreased because we worked on our identification tools that we have. What I think will happen, and that's my expectation, is that for mild HIE, there will be something like controlled low normothermia, similar to pediatrics and adults, where they compared that with complete hypothermia, and they found it was as efficient as complete hypothermia. And that will be keeping the temperature between 36 to 36.5 for 24 to 72 hours to avoid the temperature fluctuation, because we know hyperthermia and severe hypothermia is harmful. The problem is when you cool a true mild HIE babies, they are very active, and you ended up separating them from the family, and you over-sedate them to keep them still. And there are so many iatrogenic complications when you cool mild HIE babies. So what I would say for now, if you are committed for cooling, I would continue for 72 hours, but at the same time, I would work on improving the accuracy of our HIE identification. Perfect.
There are some questions about when to take the MRI. I know you review a little bit about it, but can you explain more what's the ideal moment to take the MRI?
So post cooling is the perfect window, and the reason for that, a few reasons. One, everybody's anxious and they want to know answers. Families and physicians, they want to know if there is brain injury or not. Second, that's usually the maximum diffusion changes is about day 4 to 5. And then third, some of this baby will be discharged between day 7 and 10, because if you do it day 7 to 8, then you get into the pseudo normalization window, and that window you lose your diffusion changes, and your T1 changes hasn't shown up yet. And that's because the diffusion is really measuring the diffusion of water across the membrane. So if the cell is sick, then the ATP gates is not working. So the electrolytes are going inside the cell, and the water follows that and get trapped inside the cell. So if the cell recover, then the ATP gates pumps out the electrolytes, and the water follows. So the diffusion of the water normalized. On the other hand, if the cell is dead and the membrane is ruptured, now the water again can move freely. So it cannot really differentiate between a dead cell and recovered cell. And that's the window you want to avoid. That's a pseudo-normalization. If you want to do it later, it's about day 14, day 10 to 14 you want to do it. But if I would pick one window, it's day 4 to 5. And the other reason is to be able to assess your intervention later on. When you come back and look at your cohort, if you are doing your MRI all over the map, you cannot really compare them together.
Perfect. Some questions about trophic feedings. If you don't have breast milk, would you not start any trophic feedings?
We have a donor human milk bank, so we give them donor human milk, but we don't give formula. So if there is, but any drop that mom bring colostrum, we give it. If there is no, we give donor human milk, but no formula.
The inotropes, so you would only use them when the baby is really hypotensive, very hypotensive, and they ask if this idea of perfusion and low inotropes.
Yeah, so we combine clinical and laboratory markers. So if the mean blood pressure, we have the table based on gestational age. Each gestational age have a centile. So if the mean blood pressure is below the 5th centile, and there are clinical markers, meaning like they are not perfect, but if you combine them, it will decrease unnecessary use of inotropes like capillary refill time, lactate, urine output, heart rate, etc. So if you have a combination of low blood pressure below the 5th centile for the gestational age and clinical marker, then we go ahead, and we usually start with normal saline, and then we send cortisol level as well. We start to use more and more hydrocortisone rather than giving dopamine or dobutamine. And if that doesn't respond, then we do echocardiography to see the etiology of the hypotension, and then we use it as a guide to choose the inotrope.
What about if the baby has a problem with coagulopathy, would you take him from hypothermia?
We have, if it's not responding to treatment. So we start with treating it with like vitamin K and FFP, and if that takes care of it, then we continue hypothermia. If not, if we think that the therapeutic hypothermia is worsening the DIC and it becoming harmful now, because if you think about hypothermia, it's really the principle is hibernating the brain and slowing down all the storm and the metabolism that's going on. If we started to become aggressive because the baby's sick, and we start to adding up one intervention on top of the another, then the hypothermia really defeats the purpose and increase the rate of mortality. You need to make that decision, but it's really a bedside physician at his or her discretion, because it's a clinical decision based on a specific case. There is no like a standard cookie cut for all patients.
And there are some questions about uses of erythropoietin and other medications for protection of the brain. What do you think about them?
I think erythropoietin is promising. The only caution I would say, given the nature of the injuries, reperfusion and erythropoietin stimulates the vasculature growth. So we need to be very careful. It does work at the cellular level as an anti-apoptotic agent. So if we use it a little bit later on, probably not at the early stage, it might help in neuroprotection. And if I pick one drug as an adjunct for therapeutic hypothermia, I will actually pick melatonin. Because what we have observed is these babies, sometimes their background of EEG is normal, but it stays continuous. They don't go into sleep-wake cycle. So lack of deprivation of sleep is really bad. So if you give them melatonin and help in restoring this sleep-wake cycle, maybe that will help as an adjunct neuroprotective to therapeutic hypothermia. And of course, there are other agents like xenon and others that can be used. But melatonin will be the one I would pick based on the physiology, and maybe EPO later on, not at the early stages.
We are running out of time. We will make the last question. They are talking about if hypothermia can be used for other things than just, for example, for seizures or things like that. What do you think about it?
I think it's all comes down to this timing of the sentinel event. The reason why we are not using it in stroke, for example, and it has been used in adult, because that by the time we get the babies with stroke is when they cease. They are usually fine. They go to the postnatal, and at around 12 hours of age they cease. So you miss the window of therapeutic hypothermia. And same goes to any etiology. And that's the reason why we haven't been able to study that. And without proper study, we won't be able to answer these questions. But if we could pinpoint the sentinel event of ischemia, then I think we will be able to study the impact of the therapeutic hypothermia in preventing the injury in this kind of etiologies. But for now, is the perinatal asphyxia is what we use it for. And if it's a lucky baby that we cooled thinking it's HIE and turned to be stroke, maybe that would be helpful, because the etiology is really similar. It's in stroke, it's one big artery ischemia, and in HIE is more like global ischemia.
Okay, I think we have to finish now. We would like to thank everybody for being here with us, and for you to give such a magnificent talk. I will give the word to the other presenters to thank the different sponsors.
Thank you very much. I appreciate it. I appreciate the opportunity.
Thank you.